This video is somewhat of a part 3, but also we'll just very plainly talk about the types of chest pain and the pathophysiologic basis for that. We've talked about the medications, and we've talked about how to evaluate and see if it is chest pain, and then included in one of these types of chest pain that we're going to talk about in this video, we're going to talk about MI. And really, since this is an NP perspective, I want to talk about the chronic management of chest pain. So what does your patient with MI actually look like when they come back from the hospital after going in for an MI? So really going to go into 3 types. One is stable angina. That is the classic angina. That's I'm walking up a flight of stairs. Oh, chest pain. I was outside doing gardening, chest pain. I'm not taking my medication, I haven't taken my statins for a while. Not taking my blood pressure medications, chest pain. So there are lots of people who live with stable chest pain for a long time. Is it eventually going to progress to something worse? Yes. But for right now, let's talk about the stable. So these are patients that should have some evaluation done to see, what is their LDL? What is their HDL? Do they need medications for that? And then you also want to do an EKG, see if there's been any damage. You're going to listen to their heart. Do they have any extra sounds? Do they have any murmurs? And then this patient, you're just going to prescribe them some nitrates. Listen, they got to be walking around with nitrates that are new in nature. They can't be longer. As soon as you open the bottle, they can't be open for more than 3 months. You got to get a new one every 3 months, and then you've got to keep them in a room temperature, dark area. And advise these patients, if they get chest pain, they sit down, it isn't going away. They take a nitrate, it isn't going away. They take another nitrate, it isn't going away. They take another nitrate, it isn't going away. So 3 nitrates, and it's not going away, then it's unstable. And that's eventually where your patient with stable chest pain is happening. It's going to end up, because chest pain is because you have coronary artery disease, which is a hardening and narrowing of the muscles because there's of the blood vessels, because there's plaque forming in your arteries and kind of narrowing the path that the blood has to go through. Eventually that's going to build up as red blood cells and things pass by and go to the site and get stuck there. It's going to build up and up and up until the blood vessel is blocked and occluded, and then you're going to have unstable angina. So it used to be called crescendo angina, and that is where you're going to have a very narrowed blood vessel, or you're going to have a ruptured plaque. So you have to have some really bad atherosclerosis in order to have unstable angina. So in these patients, you're going to want to do a lot of testing. You want to do a stress test, because do we want to tell a patient with heart disease, we got to tell them, you need to be exercising, you need to be going for walks, We don't want them exercising and not knowing how that's going to affect them. So a stress test will tell us that. We want to do an EKG. We want to see, there's a lot of problems getting blood to the heart and then out of the heart. So is that having an effect on the electrical conduction? And then finally, we're probably going to want to have an echo in these patients. And that is because we need to see if they're having any left ventricular hypertrophy. So there are 3 tests we're going to need in our unstable angina patients. And we're going to really consider this to be an MI until we know it's not an MI. So before we talk about MI, I just want to tell you about the last type of angina, and that is the variant angina. And more commonly, I would say that's known as Prismal's angina, and that's when you're having a coronary spasm of the blood vessel, which causes angina at any time of the day. So a patient comes into your office and says, I woke up last night in excruciating chest pain, and it was able to go away. They have Prismals or variant angina. So they just happen to get a spasm during the night. You're not going to really see that with either of the two types of angina. Okay, so basically what's happening in stable angina is you're doing fine. You have not that much room for the blood to get through at least one part of the blood vessel, but you're still okay. Then you do activity, the blood vessel narrows, there's not as much room, and that little area that the blood was getting through can't anymore. Stop activity, you're okay. Or use a nitrate, open up the blood vessel, you're okay. Unstable is an impending infarction. So a thrombus has ruptured and the patient is not doing well. What are they going to come in looking like? They're going to have the Levine sign. They're going to have a lot of cardiac risk factors. They're going to have a history of cardiac, and they're going to be in very bad pain, which came on either suddenly or gradually. So as I mentioned, we're going to do a MONA and an EKG and send them out. When they come back from the hospital to you, the nurse practitioner working in outpatient, you're going to see them on a beta blocker. Everybody post-MI needs a beta blocker. Why is this? Well, a beta blocker is cardioprotective. It's going to help to stop the remodeling. We've got to watch out for these because they do decrease the heart rate. And another thing they do is kind of make the patients just feel crappy in general. Flu-like symptoms, impotence, which means trouble getting an erection, and then I think there's one other I wanted to mention. Bronchospasm. So we want to stay with the selective beta blockers for our cardiac patients, and especially those patients who are also having COPD, because that's going to happen at the same time. I mean, these patients are not all, healthy, unfortunately. So you want to stay to metoprolol and probably metoprolol tartrate, because that is the less expensive one. You're not going to really see many on metoprolol sucrate. And the tartrate is, prescription name is Lopressor. You're going to see them on either aspirin, Plavix, or aspirin and Plavix. So if they're on aspirin and Plavix, it's going to be only a short time, like maybe 3 months or less after discharge, and then the cardiologist will take them off Plavix or take them off the aspirin. Cholesterol medication. We are going to treat these patients very aggressively. We do not want them to have any extra LDL because we don't want the vasculature getting rigid and continuing to have thrombuses forming. So watch out for the side effects here. It's muscle pain and can also have rhabdo, which is a life-threatening condition of muscle pain. Okay, the blood pressure, again, we want to treat these patients aggressively. This is America. Everyone has heart disease, unfortunately. So you can use a variety of medications, and this is where your clinical judgment is going to be really, really good. Beta blockers, they're not very strong. They do have a lot of side effects, so post-MI patients have to have that. ACE and ARBs, so that's going to be very renal protective for the patient. You need your kidneys in order to live, so using those can be really good. It's especially really very positive for those patients who are white males, because white males tend to be renin overproducers. ACEs and ARBs tend to help to decrease the renin. Calcium channel blockers are really, really wonderful in our African American males, and that's going to be one that you're going to really think of when you have an African male come in. If the patient has heart failure, a calcium channel blocker is contraindicated. That is because it causes the heart to release calcium less frequently. so that you don't have those extra beats. That's how it does its really awesome job of being an antiarrhythmic. But if you have heart failure and you have decreased beats, then your heart's going to just give up and be real sad. So we can't do calcium channel blockers in heart failure. And then the last one that I'm going to talk about right now is diuretics. And diuretics are good drugs for symptom relief. They have been shown not to decrease mortality of the patient. They do work well in conjunction with an ACE or an ARB or a calcium channel blocker. They're going to be particularly useful in the patients who are African Americans. But you do not want to use them if your patient has gout. And gout is a very American disease as well. We love our purines here. Purines are what makes gout, causes the uric acid. Purines include like beer, shellfish, red meat. So watch out for that there. And then nitrates. Oh, so I lied. I said we were going to stop talking about them, but one more. So nitrates. Nitrates are going to be a medication we've already talked about, which works on the veins in your heart to dilate. Okay. Watch these patients carefully. They're at an increased rate of having another MI, having heart failure, and they're also at an increased rate of having arrhythmias. And many of them will come back to you with arrhythmias. So if I can leave you with a parting message, it would be, do not use a calcium channel blocker with heart failure patients. And hope that helped. Talk to you later. Bye.